affiliation with the University of Utah, and Dr. Norman Foster has kindly come down to be part of this question and answer period. And we have a speaker from Boston who I will introduce in a moment. First, I'd like to invite one of our co-sponsors, so the University of Wyoming Department of Geriatric Education and the Geriatric Aging Center are co-sponsors for this program, and Catherine Carrico has a few things to say.
Thanks, Martha. And I'll be quick, and I have met many of you over the course of last night and this morning. We have some handouts about our center, the newly established Wyoming Center on Aging at the University of Wyoming. And we have this chart outside which talks about the four arms of the center, which are research, education, clinical services, and public resources. And the goal of the center is to really improve the lives of our older residents and also the people who care for and about them. So you can learn more about that out there. The Geriatric Education Center is federally funded by the Health Resource Service Administration, and they care a lot about who comes to things like this. So I have a couple forms I'm going to give you. If you can fill them out as you're here, I would greatly appreciate it. One is yellow and one is blue. The blue has some feedback about what you think of today's program, and then the yellow is some information about you. So thank you so much for doing that. We really appreciate it, and we're so glad to be a co-sponsor.
So, just briefly, the Institute for Cognitive Health has been in existence since 2009, and our annual speaker series has been in existence. This is the third year, and our primary speaker is Dan Press, who's going to give us a short talk this morning, and then it'll be open up for questions and answers on any topic related to memory dementia that you have. My plan was to have people who are full of questions, and we all are, have a couple of experts in front of them to answer those as best they can. So Dan Press, for those of you who were not here last night, I'll reintroduce him, is an assistant professor of neurology at Harvard University and Beth Israel Hospital in Boston. He should be an associate professor, but he's too lazy to file the papers. I found out yesterday. He's too busy, I should say. He's busy with important things like research. He got his 2 neurology fellowships at Harvard, neurobehavioral and movement disorders. He is on the steering committee of the Brain Fit Club, which we're going to be using as a model. We'll be getting tutelage from him and his group to start here, which I'm very excited about. He's the director of clinical program for non-invasive brain stimulation and director of the training and education of the cognitive neurology unit at Harvard. So, Dr. Press.
Thank you. I also want to thank Martha and Andy right now, who have absolutely been the most gracious hosts I've ever had for any talk up until the introduction. Right up until there you had me. Anyway, seriously though, I've had just a wonderful stay here, and I really appreciate seeing you all. And my directions are really quite clear: to keep my presentation short, to just try to give us a framework of where things stand in the field of treating memory loss, and then we're going to have lots of time for questions and answers. And if last night is any indication, you guys all have some very interesting questions. So I'm really looking forward to that part. And Norm and I have agreed ahead of time that he's taking all the difficult questions since he's more senior. So just as a way of introduction, these are self-portraits by William Witchermolen, a fairly famous artist who had the habit of once a year doing a self-portrait of himself really throughout his life. And unfortunately, he developed Alzheimer's disease, and year by year you can see the degradation in his visual spatial abilities. But all is not lost. It's rather interesting that there is actually a neurodegenerative condition called frontotemporal disease that affects a different part of the brain, where occasionally people actually develop a stronger interest in art and actually develop artistic skills that they didn't have, which is rather remarkable. I should mention right at the back that I don't have any disclosures to make. None of the research or stuff I'm presenting ends up in payments to me. I'm paid by the NIH. A number of us in the audience have NIH connections through NIH grants. That's right where my funding from. I will be talking a little bit about non-invasive brain stimulation, and at one point I'll be mentioning a research trial that's going on with that. And Beth Israel Deacon's Medical Center is a center for that trial, so I should disclose that. All right, so just as a quick overview, I'm just going to quickly talk mostly about treatment of dementia. Some of this I presented last night, but a lot of it's going to be new, and some of it will hopefully be a good review. We've had overnight with sleep to help consolidate everything, and hopefully the refresher will be all locked into all of our brains. So I'll be talking a little bit about the types of treatment for memory loss, and I'll make a strong distinction between symptomatic and disease modifying. I'll try to explain why that's such a critical distinction in the way that we're all thinking about treatments. Then I'll talk a little bit about the treatments that are currently available, including a little mention that there are certainly medications to treat behavioral symptoms, there are medications to treat cognitive symptoms, and then we'll talk a little bit about where things stand currently in terms of medications that might be disease modifying, and then I'll talk about what's in the future. So if we just start off with what are the causes of memory loss, the number one cause of dementia in the United States is Alzheimer's disease. It accounts for about 3/4, 77% of people who have died from dementia. If you looked in their brain, they had Alzheimer's changes. The second most common cause is actually related to Parkinson's disease, a series of Parkinson's-related dementias called Lewy body dementias that account for about 26% of dementia. Vascular disease, something that we talked a fair bit about last night, probably accounts for about 15 to 20%. And then there's hippocampal sclerosis and frontotemporal disease that also account for certain percentages. Now, it's usually at this point, if I pause, someone in the audience has sufficient math skills to say, wait a minute, hold on, carry the 1, here's the 0. That accounts for something like 139%. And the reason why is really a critical point that we've learned in the last few years, which is mixed dementias. These often run together. In particular, Alzheimer's disease and vascular disease often run together. Alzheimer's disease and Lewy body disease often run together. There's often a mix, and one of the things that Dr. Foster was talking about last night is trying to sort out who has what combination, because it often isn't just a pure single disorder that's causing memory loss. And as we develop more targeted therapies, it's going to become more and more critical to know exactly in which patient what mix of disorders are really causing the memory loss. But as we mentioned last night, the oldest part of the population is the most rapidly growing part of the population. So the prevalence of Alzheimer's disease is going to be increasing quite dramatically in the next 20 to 30 years as people live older. Now, we also talked about last night, something I'm not going to talk about much today, is that in fact, even though there's a lot more 80-year-olds alive now, the people who make it to 80 actually have a lower risk of Alzheimer's disease than they did 10 or 20 years ago. And we think that's due to better lifestyle interventions, better care of high blood pressure, better care of diabetes, and perhaps more education. So there's more sort of cognitive reserve. So the cohort that's making it up there is not getting Alzheimer's disease as often, but there's such a rush of older people that the numbers are still going to be growing larger. Now, these diseases begin a long time before the onset of symptoms. So if this is the line when someone is known to have memory loss, beginning 10 or even 15 years before, there's evidence that there's amyloid deposition in the brain, and then there's tau deposition. Now, I've been talking a lot about these two proteins, amyloid and tau, because these are really the two that are really thought to be the primary drivers of Alzheimer's disease. In fact, Alois Alzheimer, when he first described Alzheimer's disease, said there were two kinds of buildup in the brain, plaques and tangles. And the plaques have amyloid in them, and the tangles have tau in them. So to this day, we now understand the exact chemicals in there, the proteins in there, but he had already made really the critical discovery, which is that this is a disease of two kinds of inclusions, plaques and tangles. But this also gives us a huge window of opportunity, because there's 10 or 15 years before someone develops symptoms when things are already starting in the brain, when we could potentially intervene. So I think that's a reason for optimism. And we don't have to intervene dramatically. If we can just delay the onset, even by 5 years, we can cut the prevalence of this disease in half. So right now, there's approximately 4 million people in the United States, give or take, who have Alzheimer's disease. In 2047, that number is going to go up to 8.6 million, give or take. But if we can delay the onset by 5 years, and it looks like we're already starting to do that, we can cut the prevalence down from 8.6 to 4.6 million. It's a huge decrease. So there's a huge opportunity there through lifestyle interventions, just like what Martha has been talking about, and just like what her center is focused on. So this is the critical point that I was talking about in terms of disease-modifying versus symptomatic. Let's work our way through this. We discussed that there's a long pre-symptomatic stage before someone develops any memory problems. Then there's a stage called mild cognitive impairment, where someone has memory problems, but not enough that we can be certain that this is the beginning of Alzheimer's disease or some other form of dementia. And then there's a later stage where it becomes quite clear. If someone were to intervene with a symptomatic therapy, something that helps the symptoms but doesn't slow down the disease, it will temporarily make things better, but then the person will progress at the same speed that they would have anyways. Now, they'll always be a little bit better because of that symptomatic medicine, but they'll still be declining at the same speed. Does that make sense to everyone? So, last night I gave the analogy of cars rolling down a hill. The symptomatic medicine puts you high on the hill, but you're going to still be going down at the same speed. So if there's a whole row of cars and you are first and you get moved to fifth, you'll stay fifth, but you'll still be declining. So symptomatic therapies are useful, but they don't really do what we really want to do. And that's to make the hill less steep. So a disease-modifying therapy has a very different profile. The longer you're on it, the greater the benefit. And in particular, if you could start a disease-modifying therapy even before you develop symptoms, and then if we're being 100% honest, can I be honest with you guys? If we're 100% honest, someone then dies of something else, then they've been cured of Alzheimer's disease. That's the sad part, is we're all going to die of something. And the Alzheimer's community is trying to make it not Alzheimer's disease. Frankly, the medical community has been trying to make it not heart disease and not cancer. And they've been very effective in that. And that's a big chunk of why Alzheimer's disease is becoming a bigger and bigger problem. But now our goal is to do what they've done and push it back 5 years, push it back 8 years. That's really our goal. All right, so no one threw pitchforks at me. So let's talk a little bit about what we currently have. There are medications that are symptomatic to help with memory loss. And in particular, they're what we call cholinesterase inhibitors, drugs that prevent the breakdown of acetylcholine or raise the amount of acetylcholine, a chemical messenger that's critical for memory. But this is sort of way downstream. This is sort of it's a symptomatic therapy. One way I sometimes think about this is like if you have a cold and you take like a nasal spray to decongest your nose, that doesn't make the cold go away any faster, right? But if you have pneumonia and you take an antibiotic, that actually does make the pneumonia go away. That would be disease modifying. So the cholinesterase inhibitors look to be symptomatic. There's a number of them: Donepezil, ribostigmine, galantamine. Their brand names are Aricept, Exline, and Razodine. It's a little crazy and messy. We have two names for everything. There's a generic name and a brand name. But here's a little complicated slide, but I'm going to take you through just one critical point to show why we know these medicines are symptomatic and not disease modifying. This is the original Aricept trial, and this is Aricept at 10 milligrams and 5 milligrams on a cognitive measure. And you can see the group that got the drug did better, although they were declining at roughly the same rate as the placebo group. They were always higher on the hill. And then at the end of the trial, the medicine was stopped. And then they waited 4 weeks and retested them, and they all fell down to the same level. So that's really proof that it was symptomatic. Had it been slowing the progression of the disease and they stopped it, the people wouldn't have gotten all the way worse back to the placebo group. Does that make sense? I already have a question. Yeah?
Can you restart the drug and boost them back?
Yeah, that's a good question. Yes, it actually, in fact, early on in the days of Donepezil, there was actually a research trial that did exactly that and showed exactly that you can bump them up. And in fact, Donepezil and all the cholinesterase inhibitors look like they gave you the same boost whether you start it in the beginning of the disease, the middle of the disease, or the end of the advanced disease. It always gives you a little bump up. How much of a bump varies from person to person. On average, in ballpark, it's about 6 months. It makes it the way you were about 6 months ago. So 6 months up the hill.
Doc,
Yeah.
have they done anything to stop the nausea that comes with these pills?
Yeah, no, they have not. It's a huge problem. There is actually, so you know, one of them in particular, Exelon or ribostigmine, it has a weird sort of profile in terms of after you take it, the levels go very high and then they go down. And at the peak, people get a lot of nausea and often vomit. So Exelon has come out with a patch form that gives much more even blood level. So the Exelon patch is sometimes better tolerated than some of the others, although Donepezil is often well tolerated as well. And Donepezil is available as a generic, as is Racidine. So certainly they have side effects. Nausea and diarrhea are the most common ones. Yeah. This is counts towards my 20 minutes, by the way. If people start asking good questions, I'm answering the good questions. No, I want to answer them, buddy. Is that all right? Yeah. I'm just saying, I'm not going to be done at 20 minutes.
Based on this chart, why wouldn't you prescribe this drug to everyone?
That's a good question. Well, part of the answer is right over there. Sometimes it causes side effects.
Yeah, but if you,
What?
if I'm willing to take the side effects, why don't you give me the drug?
Norm has a different view, and he can't keep himself in check. So go ahead. For which? This side.
No, the symptomatic side.
Yeah.
There we go, okay.
Yeah.
So let me point out something. This is not, this is terminology. So there are drugs that are used to treat specific symptoms, and there are drugs that treat specific diseases. And so what you'll see here is this is Alzheimer's disease. And so just the symptom, if you have memory problems, these are not drugs that treat memory symptoms. They treat the disease. Let's see if I can go back here. Sorry, I'm going to mess you up, right? But I think it's very important to point out that we're not treating the symptom of memory loss, we're treating the disease, either Alzheimer's disease or dementia with Lewy bodies. So if I'm just an older person and my memory's getting worse, I don't have the deficiency of the neurotransmitter that would let me benefit from these medicines. And so I actually a little bit object to the terminology of symptomatic treatment. This is a specific disease treatment. Just like with Parkinson's disease, just because I'm not walking as well as I used to, we don't give treatments for Parkinson's disease. So we're actually, the question is whether we're modifying the disease, modifying the course of the disease, modifying disease pathology, or treating symptoms. So if you're depressed and have Alzheimer's disease, we have symptomatic treatments for depression. And in fact, those might be applicable to many different dementing diseases. But here we're talking about specific replacement of a deficiency of this chemical in the brain. So that's why we wouldn't treat you with with the drugs for Alzheimer's disease and dementia with Lewy bodies if you didn't have those conditions.
Right. So certainly the Donepezil has really no role just in healthy aging or in memory loss that we all notice as we get older. Nor does it even look to be all that effective in mild cognitive impairment. It's really when someone has significant memory impairment. Yeah.
What are Lewy bodies?
That's a good question. So Lewy bodies are Lewy bodies are. Remember how I mentioned plaques and tangles are in Alzheimer's patients. Lewy bodies are just like those. They're also buildups in brain cells, but it's built up of a different protein, the protein that builds up in Parkinson's disease. So everyone who has Parkinson's disease has Lewy bodies in their brain. And there are also some people who don't have a lot of motor symptoms, like you always picture someone with Parkinson's disease having tremor and walking bones. There's some people who don't have those motor symptoms, but have cognitive symptoms, including visual hallucinations, who also have Lewy bodies in their brain. And interestingly, it turns out that these cholinesterase inhibitors may be even more effective in the Lewy body conditions than they are in Alzheimer's disease. Because the other gentleman who asked, why isn't everyone on it? The reason why everyone isn't on it is it's not holy mackerel. Someone gets so dramatically better that the family comes in the next time and says, he's like a new person. Occasionally, though, patients who have Lewy body disease have that exact response. They get dramatically better. So we try to use these in everyone who, at least I believe, who has Alzheimer's disease, and certainly even stronger in people who have Lewy body disease, because the potential for benefits is even bigger. All right? Good questions, yeah.
Do the medications for Alzheimer's help people with FTD?
That's a good question. The short answer is unfortunately no. So the buildup of proteins in FTD is very different from Alzheimer's disease. In FTD, it's two different proteins, just like in Alzheimer's disease. It's either tau or TDP43. And there's work on creating tau therapies, because tau builds up in both FTD and in Alzheimer's disease. So if you had a tau therapy, it could potentially work for both those conditions. But some people with FTD have tau buildup, and some have TDP43 buildup. I think the major breakthrough in FTD research is that we can now, for the first time, image tau in the brain. I'll show you a slide of that. So we can sort out when someone has FTD, which kind they have, which protein is building up in their brain. And that's going to be really the first step, so that we can then see if some drug can clear that protein out.
So FTD does not have the acetylcholine.
They don't have, so they wouldn't get better from a cholinesterase inhibitor.
But the fact that you identify it doesn't reverse it. There's no drug to reverse.
Correct.
I've just had to place my brother in a home.
Yeah. So FTD, just for the people who don't know, so FTD is a condition that affects people on average at a younger age than Alzheimer's disease, with a mean around 60, and can even occur as early as 40 or even younger. And it often affects behavior and language much more than Alzheimer's disease does. And we all hate it because it's a tough condition. And frankly, we have the symptomatic therapy that we have that's equivalent to Aricept is probably the medicines called SSRIs, or serotonin reuptake inhibitors. Medicines like citalopram and or Celexa and Zoloft or sertraline. Those medicines can help some of the symptoms, just like Aricept can. And it's probably for exactly the reason that Norm was mentioned. In FTD, there's a decrease in the amount of serotonin more than acetylcholine. And so drugs that raise the amount of serotonin can be beneficial.
What does FTD stand for?
Frontotemporal disease, or frontotemporal dementia. It's a series of diseases that attack specific lobes of the brain.
One more question. I won't dominate on this.
No, it's,
my brother,
yeah,
up until just recently, was
Yeah.
able to ride a bike 20, 30 miles a day.
yeah,
Come home,
yeah,
and he would be not normal, but
Yeah.
he'd be much better than he was before he left. He had,
Oh,
he had a
excellent.
high.
yeah.
What is the chemical that does that? Why can't you capture it and put it in a pill?
Yeah.
Keep it that way all day.
They probably can, it's probably morphine. So Martha and I have had this discussion before that exercise, I think we've all had sort of or a lot of you guys look fitter than I do, get an exercise high after doing something like that. And it seems to be endorphins. It's actually endogenous forms of morphine, or a chemical that's like an opiate that's produced in the brain naturally from exercise. But I've not heard anyone suggest using it the way you're suggesting, which is an interesting idea. It turns out, by the way, that the runner's high that one gets is definitely related to morphine or heroin, because if you give the drug Narcan, the one that reverses morphine, to someone who's got the runner's high, you make them feel really terrible.
And all kidding aside, the morphine
Yeah,
Is that a treatment? I mean, is that something that's?
it's not been looked at.
It
It's
won't
not been-
produce a high or?
It would produce a high. It would produce a high just like a drug of dependence. But the problem with it is it's a drug of dependence, so it could be habit forming and have all those
Wouldn't
problems.
it be better to be habit forming and live a decent life?
That's why I said it's an interesting idea, because certainly someone who's got frankly a fatal condition, you know, the downsides of trying something like that are low. It's uncharted territory. Let me just leave it that way. Yeah. Okay.
Thank you.
Yeah, no problem. So we were moving on. We had our first battle of the morning. So moving on. So this is just to remind everyone about the two kinds of inclusions in the brain. This is actually a slide from a patient who I followed until she passed away. We did an autopsy on her at her request, really, showing the brain changes of Alzheimer's disease. This is an example of a plaque right there. That's a buildup of amyloid, or A-beta. A-beta is the short term for amyloid. And A-beta is a protein, and we know exactly how it's produced. It's cleaved by enzymes called beta secretase and gamma secretase. And the reason why these names are worth knowing is we've already spent, say, $400 million testing gamma secretase inhibitors to treat Alzheimer's disease. And there's a trial starting with a beta secretase inhibitor with the goal of preventing the formation of amyloid. And I'll talk about another strategy for getting amyloid out of the brain in a minute, a vaccine strategy. But those are probably the two major strategies that are being tested on this amyloid path. But the other inclusion is this. This is a tangle inside the nerve cell. So this is the nerve cell. This is a tangle inside. What a tangle is a buildup of a different protein called tau. There's a lot of excitement about tau. A colleague of mine, Keith Johnson at Mass General, has a way of imaging tau, and he was walking around the Alzheimer's meeting pretty much screaming out, "Tau is now." There's a lot of emphasis on tau these days because tau, the amount of tau in the brain seems to correlate with the cognitive deficits, and a number of the therapies that are aimed at amyloid haven't been effective. So there's a long pathway, There's a long pathway from amyloid to all the way to cells dying. The goal is to work our way up that pathway and get closer and closer to where the pathway begins, to work at the initial formation of either amyloid or tau. And as we discussed, these changes occur a long time before. So I'll just quickly go over what is known now about therapies. There's vitamin E. Martha and I were having a healthy discussion about whether vitamin E is actually beneficial or not in Alzheimer's disease. There's been 2 trials to suggest that it is. They weren't mammoth, the effect wasn't mammoth, but it was real. And I would say that the data for vitamin E are fairly good, and it's also really quite safe. There's been some worry that vitamin E might be bad. It was largely based on what's called a meta-analysis. They looked at every single study that ever gave vitamin E for anything, for heart disease, for cancer, for any condition ever. And on average, there was a few more studies where it looked like vitamin E wasn't safe. Any dot above this line meant that it increased mortality. But the Alzheimer's study is this lone dot down here. So in Alzheimer's disease, it actually seems to lower mortality. And then the last one that we don't know if it's disease modifying or not is memantine. It's a drug that works in a different way than Donepezil and the cholinesterase inhibitors. It actually works on glutamate, and it actually seems like it works to prevent something called excitotoxicity, which is a mechanism by which nerve cells die. The odd thing about memantine is that it doesn't seem to work in the mild stages of the condition. It's been tested 3 times now in mild AD and not shown to be beneficial, but in both moderate and severe AD, it actually does seem to be beneficial. Okay, so we want to work our way up. So last night we briefly talked about this other strategy. So I mentioned the drugs that might inhibit the enzymes that cleave amyloid, that form amyloid, like gamma secretase inhibitors. The other strategy is an immune strategy, using one's own immune system to help clear amyloid out of the brain. This is a radical idea developed by Dale Schenk, where there are mice that have been genetically engineered to develop Alzheimer's disease, to develop amyloid plaques in their brain. And we can debate later how good of a model they are, but they do develop plaques just like humans do. And this is an example of plaques in the mouse hippocampus, the part of the brain that's critical for memory. And Dale then gave one of these mice a vaccine of amyloid, gave them amyloid with the goal of them generating antibodies to the amyloid to see if the antibodies could literally suck the amyloid out, basically. And in fact, it worked. You can see there's no more plaques in this mouse. And this quickly led to human trials where also a number of people seemed to have clearing of the amyloid plaques, only it wasn't clinically effective. In fact, a number of them continued to progress. And the thought now is that it may be too late in the disease. We may need to work on amyloid earlier, and I'll show you exactly what I mean by that. The other major breakthrough that we've had is in PET imaging, like what Norm does, which is up until recently, we've only had this kind of PET imaging, FDG PET. This is a way of looking at the metabolism of the brain, and this is a typical PET scan with this FDG PET of someone with Alzheimer's and someone who doesn't have it. And I think you can sort of see that there's less reds and less yellows here than here, but it's not exactly night and day. But we can now finally image amyloid in the brain, the protein that we've been talking about, and that looks dramatically different between controls and Alzheimer's disease. So our ability to actually be sure someone has amyloid in the brain is new. It's only been around for the last 9 or 10 years. And it's now widely available. There's a form of it called Florbetapir, which is widely available at a number of hospitals that also does a good job of showing whether there's amyloid in the brain. Doesn't mean someone has Alzheimer's disease, just means they have amyloid in their brain. And finally, we now have a way of imaging tau as well. This is a slide nicely given to me by Keith Johnson. The tau is now guy, showing that you can actually see tau building up in the parts of the brain that are critical for memory in someone who has very mild memory loss. I was going to talk about, so there's a number of clinical trials going on, but a number of them aimed at amyloid in people who have mild to moderate disease have failed. So there's a trial of bapineuzumab in people with mild to moderate AD that failed. Solanezumab in mild to moderate AD failed. There's a number of other trials that failed. But in the solanezumab, in one of these antibody trials, if you separate out the people who have mild symptoms from those who have moderate, the mild group actually look like they might be a little bit better. And there's now a big move on to use these vaccine strategies in people who have mild AD or even very mild or even pre-symptomatic. And I'll talk a little bit about that because there's a study going on called the A4 study, which I'm quite excited about, where people, where people don't even have myocardial impairment yet. They're perfectly healthy. They have no memory loss at all. Go for a PET scan. We see if there's amyloid in their brain, and if there is, they then get put on solanezumab, the drug that I mentioned, with the goal being, can we take the amyloid people who normally would progress to myocardial impairment and bend the curve? Literally prevent that onset of symptoms, shift it back 5 years, just like what I was talking about. Right? I was going to talk about brain stimulation, but I think I'll be very, very brief and say that so far we talked about mostly about medicines, but one of the areas of interest at our center is directly stimulating the brain non-invasively with very powerful magnets, which can create a small electrical current on the surface of the brain, not enough to hurt the brain anyway, but enough to stimulate, to get the nerve cells firing. And we're very interested in 2 brain stimulation techniques. One is transcranial magnetic stimulation, and one is transcranial direct current stimulation, as ways to increase the plasticity of the brain while someone's doing cognitive exercises. So we talked last night and a little bit this morning about how cognitive exercises can be beneficial. The goal of this is to see, can we make the part of the brain that's doing that cognitive exercise more plastic? I guess almost like giving steroids to an athlete. You sort of boost up the brain so that when you do the cognitive exercises, you get more out of it. And there's a study going on called NeuroAD from a company out of Israel that combines TMS with cognitive exercises, and the TMS stimulates different brain areas while someone does a cognitive exercise for that area. So that's a whirlwind tour, but I think the highlights I wanted to mention was some of these issues around disease-modifying versus symptomatic therapies. The fact that there's some new therapies, particularly ones that aim at the enzymes that produce amyloid or antibodies to clear amyloid out of the brain. And that is looking more and more like, at least for the amyloid therapies, they need to be given very, very early. One last thing I would say is that strategies that work in one set of diseases may work in another. So this vaccine idea is now being started to look at in FTD to see if the proteins that build up in FTD can be cleared out the same way by a vaccine strategy. So a little bit further behind, the development isn't as fast, but it is coming along. So.
Thank you very
Yeah,
much.
just wait, yeah.
What I was going to suggest is that I know there's more questions for Dan, but we also have Dr. Foster here, and we can go ahead and just formally start our panel.
Zach's going to be
And Zach Hall is going to be our mediator. I'd like to introduce Zach. We're very fortunate to have him on our hospital board. He is a neuroscientist who trained at Harvard and has been director of the National Institute of Health Department of Neurology, which has a neurology and Institute for Neurology and
neurological disorders and
stroke. Yeah, so very long.
NINDS, that's the short.
And NINDS, yeah, and continues to be very active in neuroscience and on various boards. And Dr. Norman Foster, who, again, if you weren't here last night, I'd like to introduce him. He has a very long, detailed CV like everybody else. He was recruited to be found the Memory Center at the University of Utah in 2005, I believe, and is director of the Center for Alzheimer's Care, Research, and Imaging. So he's a clinician and researcher, just as Dr. Press is. Both are very published. We work in affiliation with him. He's my mentor and colleague. We are doing a treatment for free for veterans for proactive dementia care through the graciousness of Dr. Foster's and his ability to get grants from the VA. We've been doing that for 3 years, and we have many collegial relationships. So I'd like to introduce everyone. Dr. Hall will be our moderator, and if you would come up here, and I'll try to answer some questions, but I'm probably going to be pretty quiet.
Is there a formal microphone? I can just stand over here. The expert. Yeah. Okay, let's do that. Let me just say to begin that we are, in fact, tremendously fortunate to have these two experts in the field of Alzheimer's disease.
I feel fortunate to be here looking out that window at the beautiful scenery.
That's why we're all here, one way or the other. But we are indeed fortunate to have them from Boston and from Salt Lake City because they bring with them the very latest in expertise in clinical treatment of these diseases, which are so extremely important. Let me, if I may, make a brief point first, and that is, as Dr. Press alluded, there's a group of neurodegenerative diseases, all of which have different symptoms, but seem to have a common pathological theme, and that is they all seem to arise from the aggregation of proteins, abnormal aggregation of proteins in cells in the brain, with resulting dysfunction and death. The particular neurons that are affected by these different proteins are different, and it is these neurons that give the different symptoms of the diseases. And those diseases include Alzheimer's disease, frontotemporal dementia that we talked about this morning, Parkinson's disease, ALS, or Lou Gehrig's disease, Huntington's disease, all of these. And one of the hopes is that out of the study of each of these diseases, Alzheimer's being one of them, we will discover things that will help us treat all the diseases. And that's, I think, a very real possibility. Of these diseases, Alzheimer's is by far the most important in the sense of society, cost to society, and personal burden. And I would just like to ask how many in this room have had the experience of having a person with Alzheimer's in their family or close friend. And you can see how pervasive this is. And for many of us, we are at the age where we are either taking care of parents with Alzheimer's or we are facing perhaps prospect ourselves and our concern. And I'll end on one note. When I was in Washington, one of my jobs was to testify before Congress each year on behalf of the budget for the institute that we had, and trying to convince them that the work we were doing, of course, deserved a substantial commitment on the part of the government for our budget. And a particularly colorful scientist in our field named Alan Roses testified one year, and he's the man, for those of you who know, who discovered the importance of ApoE4, which is a protein and a mutation in that gene gives a severe form of Alzheimer's disease. But he said, there was a panel of one of the members, this was a House committee set up there, and he said, gentlemen, and I think in fact they were all gentlemen, he said at that time, this is 20 years ago, gentlemen, he says, I'm here to tell you that by 2050 there are only going to be two kinds of Americans. And he says, and I'm not talking about Democrats and Republicans. He said, I'm talking about those with Alzheimer's and those taking care of them. I think that's a particularly vivid statement, pungent as is his personality, but very vivid statement of the problems it faces. So with that, let's turn it over and have some questions. Start with John Denver.
Dr. Press, could you talk about the Brain Fit Club, or there are other activities we can be doing that?
Sure, absolutely, yeah. So this is something that a number of centers are starting to converge on, but I think we're pretty close to the forefront in terms of the idea of assessing people who are showing normal aging, seeing where they stand, and talking with them about interventions that might be multifocal. So it might involve cognitive exercises, because there's growing evidence that they can be beneficial. It might be doing mindfulness, which is a way of sort of relaxing, lowering the heart rate, and possibly deactivating certain regions of the brain. And also sort of fitness interventions, including Tai Chi and others. And I think one of the things that we're bringing to it that's hopefully a little bit novel is really clear scientific measures of where someone is at the beginning and at the end of the intervention to see what kind of difference it's making for that person. But we also try to do it in a setting that's social and fun. Because one of the things that Nora and I were talking over breakfast is, it's always striking to me that scientists have pretty much proven that positive reinforcement drives behavior and that negative reinforcement doesn't. So if your doctor yells at you and says, you need to exercise or something bad is going to happen, even if something bad is really bad, you won't start exercising. Whereas if your spouse says, honey, if you exercise today, then we're going to go out to the movies and I'll give you an extra big hug when you get back. Suddenly your spouse is out there jogging, and next thing you know, they whipped off a half marathon or something. So positive reinforcement really drives behavior, and that's one of the goals of our Brain Fit Club, is to try to make it a positive, sort of fun intervention.
You can even promise endorphins.
Exactly right.
Martha, you want to say a word about the plans for such a club here?
It was happening. Yeah.
So one of our hopes for the following year is to, Dr. Press's group are doing consultations to help other places get set up with this program. And we're going to find the space and the money and the equipment to do the same thing. May require a lot of communication back and forth, but we are looking at this as a model that we want to use here in Jackson and in the region.
Yeah, we couldn't be more excited about it because as we work out,
money.
That's right. As we work out these interventions, we want to get them out to as many people as
question? Let me take this woman's first. I think you spoke before, so let me ask right here.
With the PET scan, would you be able to do early onset of the disease or mild onset, or is it not affected earlier?
Dr. Foster, you want to answer that?
Yeah. So the question is, do the PET scans, could they show early onset disease? Maybe you could just explain, what does a positive amyloid PET scan mean? Which is an area of intense controversy, as you know.
One of the things that has been interesting is that Alzheimer's disease, as we define it clinically, is very similar no matter what the age of onset. So the FDG PET scans are similar. The biochemical changes are similar in people who have Alzheimer's disease with their onset at age 40 versus age 70 or 80. It's very difficult to distinguish those diseases except by age. So young onset, late onset, we kind of treat them the same way, although there is more likely to be a known genetic cause in those who have young onset. The information that Dan was sharing is based upon young onset genetic forms of the disease. So on the basis of that, we think that, or we know, that amyloid pathology begins 15 years on average before symptoms begin. And that's because we're following, or actually in these studies, are cross-sectional studies, looking at people who have known mutations. I think a very interesting and unknown question is whether that also is true for us, that is, for people who don't have a genetic mutation. What we know is that it's very uncommon to have positive amyloid PET scans before age 60, and that it becomes increasingly common with increasing age. What the delay is there for us is unknown, and is one of the things that the A4 study will be really examining.
Right. So put it another way, if you do these amyloid PET scans in a group of 70-year-olds who are perfectly healthy, don't have any memory loss, about 15% of them will have positive amyloid scans. What we don't know, and what's a matter of intense controversy, is are all of them going to develop Alzheimer's disease? Is it going to be 5 years, 10 years, 15 years? Or is it still 20 or 25 years away when that amyloid scan turns positive? And that's critical in two ways. One is, if it's still 25 years away, it's likely that something else that could catch up with that person, and wouldn't make sense to treat it. And the second is that interventions like Norm and Martha and I have been talking about, maybe that could help someone with a positive amyloid scan push back Alzheimer's another 5 years. And so right now, no one's recommending sort of screening with this scan, unless it's part of a research trial like the A4 trial. In fact, it's not even really being done diagnostically much anymore, although it probably would be quite useful. The funding agencies don't think that it's critical yet, because we don't have an intervention that's directly aimed at amyloid that we can give in the clinic.
Let me make a point here, though. If we're going to find such an intervention, and you believe the disease starts before cognitive defects are apparent, then you need some sort of marker in order to discover agents that will block it. So there's a big emphasis now on finding early pre-symptomatic diagnosis of
The way,
a variety of ways that may be done.
Once we have a therapy that we know works, then getting this PIB scan, I can't go with a better analogy, but I really think of it almost like a colonoscopy. Just like a rite of passage, when you turn 50, you get your colonoscopy. It may be when you turn 65 or 70, you get your amyloid scan. And if it's positive, then you go on to medicine even before the symptoms come on, just like you would have a polyp clipped out even before you develop colon cancer.
I want to address this a little bit too, because the question about whether this is an appropriate approach is actually going to be answered by people like you. So we talked about the A4 study. I think it's scientifically very important. We're going to learn a lot about it. But one of the questions that I'm uncertain about is how practical it is. So we will find out to see how many people enroll in this research study. It involves an infusion that is done monthly. I forget if it's 2 years or 3 years. It's 3 years. It's a study. And so whether people who are entirely asymptomatic want to spend, to get infusions, that much, it would be probably for the rest of their life, potentially. We don't know how long it would go on. And of course, as a society, we'll be deciding that too, because right now each infusion roughly is going to be costing about $5,000 to $10,000. So the practicality of this will be tested in part of this trial too. People who are in this study do not have to pay anything. And they may be actually able to receive some modest stipends to participate.
Sure.
But this, there's the scientific part and then there's the practical part. And if society and people are interested in receiving these kinds of treatments while they're asymptomatic, that's good. I think it may be a matter of principle. We may need to come up with a cheaper, more easy way to prevent the disease.
We have a question here, person over here, and then here and here. Okay, and one over here. All right, so if I can remember that. This is a little complicated. We'll start with you.
How much of this is genetic?
Yeah.
I worry because my mother had Alzheimer's, my brother has FTD. Why happen?
Yeah.
Second, why does it rage through some people and death comes within a couple of years? In case my brother has been 10 years and he's just going into a home. And I know other people have died within 2 years.
Dan, you want to take that?
Sure. So the first question is what percentage of it is genetic? And it's interesting. So first I would say most times it isn't strongly genetic. So strongly genetic to me means if your parent has it and you inherit the gene, you will get the disease. About 1%, only 1% of people with Alzheimer's disease will have a familial form of it, where they develop it under the age of 60, say at 50 or even 40, and in those people, it's always a specific gene that they inherited from their parent that got it. In the people who develop Alzheimer's disease over the age of 65, like the vast majority, 99% of them, there are some genetic factors or a little bit of risk factors, not unlike the genetic factors for heart disease. So if your father had heart disease, it makes it a little bit more likely that you'll have heart disease. But if you take good care of your cholesterol, your blood pressure, and anything else, you won't end up having a heart attack just because your father did. So that's what I would say. The second question you asked was about frontotemporal disease and Alzheimer's disease. Early on, I made a point about how these diseases often mix together. In particular, Alzheimer's disease, vascular, and Lewy body disease. It turns out FTD does not mix with any of those. It's totally its own separate thing. So for you in particular, just because your dad had Alzheimer's or your brother had FTD, each of those are independent sort of issues. Your dad having Alzheimer's makes it a little bit more risky, but not a lot for you. The fact that your brother had FTD, it would depend on whether any other members of your family had FTD. But if he was the only one, then that also wouldn't be a risk factor, because the large majority of FTD is spontaneous, something about 80%. There's about 15 or 20% of the time that FTD travels very strongly in families, but that's also the minority, although not quite as rare as it is in Alzheimer's disease.
Doesn't it also make you wonder if it was...
Did you have a question?
Oh, yeah. So one last question is about the accuracy of the diagnosis. One critical point is on both ends, to be really sure that what your father had was Alzheimer's disease, and what your brother has really is FTD. That's the point that Norm's been making, is we're sometimes wrong. We're about 85 or 90% accurate in our diagnoses, but not 100%.
And I want to answer the second half of that question, which is, why is it that some people who develop Alzheimer's disease that look exactly like someone else progresses over 2 years to death, and others over 20 years to death. And we've recognized that there's a lot of individual variation. The best way to predict that is to look at the individual over a period of time, and then you can actually trace what the rate of progression is for that individual. What are the factors that determine that? There are many of them, but I want everyone to go away from here realizing that Alzheimer's disease and other dementing diseases are treatable diseases. They're not preventable by and large now. They're not reversible. They're not curable, but they are treatable. And a quick story related to that is that 2 decades ago, when the Aricept trials were beginning, people were progressing at a much more rapid rate than they do today. So even though there's not the evidence of disease pathology modification, people are surviving better, and that's because we're less likely to sedate, restrain, and institutionalize patients than we did a decade or 2 ago. And people do better when they're not restrained, sedated, and institutionalized. So one of our goals is to try to keep people at home as active as we can for as long as we can. And those are worthwhile efforts, I believe. And things like BrainFit is relevant.
Question over here. Somebody had a hand over here. I think earlier. Okay, go ahead. We got several of them.
Yeah, I just wanted to make sure that I was understanding what I think the point is you're making. There is no, if you're not symptomatic, there is no screening device right now that either exists or is recommended as a general part of preventive.
Right. So the question is there a screening test right now? You're correct, there is not a screening test right now. We do not yet have the colonoscopy, so to speak, because we don't have a proven way to remove polyps. We don't have a proven way that knowing that would actually lead to an intervention that would help. The trial to test what I believe to be the best shot at that is just starting right now. And like Nora mentioned, there's a lot of challenges in that trial, and it's probably 4 or 5 years away before we have the answers. But I think that time horizon is a lot smaller than it was 10 or 15 years ago, when we didn't even have a way to even think about that.
Question back here, and then Carol, and then over here. Yes?
In regards to the treatment of individuals with Alzheimer's who have developed aggressive and agitated behavior, can you hear me?
Yeah.
Almost.
Yeah, progressive
Aggression
agitation.
and agitation,
Yeah.
and specifically the use of psychotropic medications, the antipsychotic medications. You started touching on sedation. What is appropriate and what medications have been shown to help with severe aggression and agitation?
So the question is about agitation. So unfortunately, people who develop Alzheimer's disease have a fairly high risk of agitation. It increases as the disease progresses, so that by moderate disease, about 50% of people with Alzheimer's disease will at least intermittently be agitated. And the way I think about this is agitation is kind of like a fever. It just means there's something wrong, but you don't know what's causing it. In the most likely way, the best way to treat agitation is to figure out what the triggers are in each individual person. Because when we've done clinical studies of giving some drug to everyone who's agitated, it's never worked. And the analogy I give is like, if you called the doctor and you said, "Doc, I'm short of breath," he wouldn't call in a prescription. He would say, "Are you short of breath because you have asthma or pneumonia or heart failure?" He would do so, or she would ask a whole bunch of questions to sort out what was the cause, and then do the treatment. So agitation, if it's caused, sometimes it can be caused by something as simple as a bladder infection. And then treating the bladder infection would be the treatment. But you never see a research trial of Bactrim as a treatment for agitation. Do you know what I mean? Sometimes it's depression, and the person's having a hard time verbalizing it. Sometimes it's poor sleep hygiene, and they're napping during the day and awake all night, and that's causing distress to the family. I think that the most effective treatment is to take time to try to figure out what the individual triggers are, and then come up with a program to treat those triggers. Occasionally, it is truly caused by hallucinations. fears that there's someone in the room, or even seeing people, particularly in that Lewy body condition. And there, some of these atypical neuroleptics can be beneficial. But it's probably a subset, and probably a relatively small subset of the agitated people. And I think that's why it's been so hard to just treat agitation as a single thing with a single drug.
Thank you. Question here?
Yeah, I think I wanted to clarify, you had a chart up on those numbers of millions, between now and 2050, and then you said it could be reduced. And I think I just need to review what it was that was going to reduce those numbers. I believe you mentioned something about blood pressure medication?
Well,
was that related?
No, so those numbers get reduced by any intervention that can prevent the onset by 5 years. So if you can prevent the onset of Alzheimer's by 5 years, whatever that intervention is, whether it be a brain fit club, whether it be better care of diabetes and blood pressure, whether it be going on solanezumab when you have a positive scan, whatever ways we can push it back by 5 years will cut down the prevalence. That's the point.
There's a relationship with blood pressure and onset.
So the risk factors for Alzheimer's disease include, we discussed this a little bit last night for those here last night.
Why don't you say more about that, because you made a strong point last night.
Yeah, so all the risk factors for Alzheimer's disease, here they are. Here are the known ones that are modifiable. High blood pressure, diabetes, high cholesterol, and a sedentary lifestyle, and obesity. If you say, what are those risk factors for? You wouldn't say Alzheimer's disease, you would say heart attacks. Every one of those are a risk factor for heart attacks. And there's a very, very intimate relationship between vascular problems that can cause heart attacks and Alzheimer's disease, as it turns out. And it's intimate in ways that we're only starting to sort out now, but we know those are all modifiable risk factors. And so anything that, it turns out anything that is good for your heart is good for your brain.
Question here. That's you.
You mentioned excitotoxins. Are there any dietary natures that you take to avoid excitotoxins?
Right, yeah. So excitotoxins or free radicals, I always like the free radical terminology. It reminds me of like Sleeper Cell or some TV show where there's like a 9/11 guy on the loose. So free radicals are thought to be involved in these conditions, but unfortunately the main ones let me back up. The drug that is currently available that works on that strategy is vitamin E. And the evidence for vitamin E being helpful in Alzheimer's disease is actually, I think, fairly good. We can debate it, but there's been 2 clinical trials of it. Now, the evidence that vitamin E can work earlier on, before someone's development memory loss, is actually scant. And there's some evidence that it doesn't help.